So our second subject is what is bariatric, metabolic, or weight loss surgery? These procedures we're going to be talking about today really are tools. They are not a complete fix or a total cure for anything, although they can put things into very complete remission in terms of diseases, and they can be lifelong useful tools. What these tools do, and you see we have two different portions here, they do help control calorie intake and absorption, and that is mainly through hunger hormones, which both control your appetite before and between meals, but then also give you a feeling of satisfaction, or satiety is the term we use, at the end of meals, so that you actually feel satisfied on a much smaller amount of food at a given feeding. Now, because almost all of these procedures do result in a smaller stomach, that does give some behavioral reinforcement in terms of limiting the speed and the amount of meals as well. It's not just satisfaction. If you overeat, you will feel too full, but that is not the primary way that these things work. Now, the malabsorption component of weight loss surgery is generally not as much of a factor as most people think. You're not actually eliminating calories into the toilet at the end of the day. Most of these calories are absorbed, you're just eating less. And in the case of diabetes, you're absorbing the calories a bit differently in terms of the way your insulin communicates with the gut and the liver in that endocrine system. So put it another way, weight loss surgery and diabetic surgery is an alteration of your anatomy that gives a metabolic effect, and that works against diabetes and cholesterol diseases in addition to those hunger hormones. And that is a direct effect, especially from gastric bypass, that we see even prior to weight loss. Now we're going to go through this step by step as well, but as an overview, that's an introduction. Now, just to talk about obesity in particular, a body mass index, which is a height versus weight index, traditionally people have used the shorthand of saying, oh, 100 pounds overweight. With recent findings in the literature, you can see here that people do not necessarily have to be 100 pounds overweight to be in the obese category. What we originally used as severely obese category was about 100 pounds overweight for most people, that body mass index of 40. But we're finding through research that more people in lower body mass categories, BMI of 35 and BMI of even 30, can benefit, especially if they're diabetic or have life-threatening comorbidities, or have life-altering morbidities such as severe arthritis or stress incontinence or infertility. I'm sorry I don't have this in metric right now, but it's very easily figured out on the web or with calculation if you use metric. Now in 1991, when early research was still going on, weight loss surgery had been around for about 30 years at that point. It was actually started as anti-cholesterol surgery. Really, metabolic surgery came before weight loss surgery. But in order to do better research, the National Institutes of Health convened a consensus panel to start researching with more discrete groups and cutoffs, and they came out with these criteria, again as a starting point, that anyone with a body mass index of over 40 was felt to benefit if they desired from weight loss surgery, and anybody with a body mass index of 35 or over with these comorbidities, weight-related health problems, type 2 diabetes, sleep apnea, asthma, reflux, high blood pressure, high cholesterol or lipids, heart disease, reproductive problems, especially polycystic ovary syndrome and infertility, severe arthritis, urinary stress incontinence, and now we've come to find also as well, this is not historical, but now cancer risks as well, that if those folks desired surgery, that they should not be withheld surgery. This has sort of been turned inside out from the insurance companies, because now, 20 years later, our research is showing that people with a body mass index down to 30 have great benefit, and particularly in diabetics, even below a body mass index of 30, people have benefit. But this early research criteria has been sort of set by the insurance companies as a set in stone, and that really was not the intention of those consensus panel members. But that's where we started, and that's what you'll hear in the literature of, well, what's the BMI cutoff? In the meantime, though, over the last 20 years, and especially in the last 5 years, we've seen a real growth of research studies strictly for diabetes control alone, and not necessarily trying to make people lose weight. And in fact, some of these studies are looking at people who don't even have a weight problem to try to find an operation, because we see such strong gut hormone changes to alter these operations so that people who are skinny but have diabetes, type 2 diabetes, don't lose weight but do have the same benefit. Most of these operations do have some weight loss though, and certainly we don't want to operate on somebody who has low weight, because we probably will drive them into an underweight category, but that's where more research is being done. There have been 2 international congresses over the past few years, and also many peer-reviewed studies, statements by major diabetes societies regarding the benefit of metabolic surgery. There's really not a clear consensus yet, and it will probably be many years before we have a lot of these things completely worked out. We're still working out even the best way to take out an appendix, 100 years, 130 years after the first appendectomy. So don't expect necessarily clear-cut answers from science. I do expect there will be more and more data coming out even in the next year or two. Early results show that the gastric bypass type operation, where food is diverted to go around the stomach, does seem to be the best overall at this point, most effective.